When you first find out you're pregnant, it feels like you're handed this incredibly detailed, almost universally understood roadmap.
Oh, absolutely. It's like a totally standardized expectation of what your body's going to do.
Right. Like week 12, the baby's the size of a lime. Week 20, you might start getting heartburn. Week 30, your lower back will probably start aching.
Yeah, the milestones are almost treated like a guarantee.
Exactly.
And it creates this illusion that pregnancy is just a completely mapped out biological event, right? Where every single symptom has its own dedicated chapter in some best-selling guidebook.
But then you step off that well-worn path. You experience a symptom that, well, it isn't in any of those popular books.
Yeah, the stuff they don't warn you about.
Right. You aren't just dealing with the standard nausea or like fatigue. You're dealing with something entirely unmapped for the average person.
Which can be terrifying.
It is.
Yeah.
Suddenly that roadmap just vanishes and you're standing in the middle of a diagnostic wilderness.
And, when that wilderness involves a chronic, highly intimate skin condition, the silence from the standard medical literature can be, honestly, it can be deafening for the person experiencing it.
It really can. So welcome to the deep dive. Today we're taking a stack of medical guidelines, clinic FAQs, and some really recent dermatological research.
Lots of research to get through today.
Lots of it. And we are focusing on a highly specific, often totally misunderstood intersection of women's health. We're talking about lichen sclerosus and pregnancy.
It's a topic that desperately needs more attention.
It really does.
Yeah.
And let's just start by directly answering the primary question that probably brought you here today. Can lichen sclerosus actually develop during pregnancy?
The short answer is yes.
Right. Yes, it absolutely can. But the real fascination, I think, lies in the mechanics. Like how and why does that even happen?
Well, to really understand those mechanics, I think we need a clear picture of what lichen sclerosus or, LS actually is at a baseline.
Yeah, let's establish that first.
So it's a chronic inflammatory skin condition. And while it can technically appear anywhere on the body, it primarily affects the genital area.
Yeah.
It causes these white or pale patches, a crinkling or thickening of the skin, and this severe, often just debilitating itching.
And micro tears too, right?
Exactly, micro tears. And over time, if it's left untreated, the inflammation can cause the skin of the vulva to actually scar and fuse together.
Wow. That sounds incredibly painful.
It is. And because it's such an intimate issue, it's heavily under-discussed. I mean, it's often misdiagnosed as just a standard yeast infection for years.
Which is so frustrating. Okay, let's unpack this.
Yes.
We know LS can develop for the very first time during pregnancy.
Yes.
Like the research explicitly documents cases of people receiving their very first diagnosis while pregnant.
Yeah, that definitely happens.
I'm just trying to wrap my head around why pregnancy, which is, a natural biological process, would suddenly trigger a chronic autoimmune-linked skin condition.
I mean, it really comes down to a profound physiological pivot. When a person becomes pregnant, their immune system has to undergo this massive systemic shift.
Because of the baby.
Right. Think about it from a purely biological standpoint. You are growing a fetus that shares only half of your DNA.
Right. The other half is from the partner.
Exactly. So to the maternal immune system, that fetus is essentially a foreign object.
Oh, wow. So the immune system basically has to act like a border control agency that suddenly lowers its defense protocols.
That is a perfect way to put it.
Because if it stayed at high alert, it would just attack the baby.
Exactly. The body has to actively suppress certain immune responses to tolerate the pregnancy. But, when you mess with the border control, other things can slip through.
That makes a lot of sense.
If we look at the biology of LS, it's driven by inflammatory cells, specifically T cells, and they collect right at the junction where the top layer of skin, the epidermis, meets the deeper layer, the dermis.
Okay, so they're just hanging out there.
Right. And these rogue T cells release proteins that completely upset the normal structural balance of the skin.
So it's kind of like a microscopic trench war happening right under the surface of the skin.
Yes. That's a great way to visualize it. So when pregnancy wildly alters your hormones and, suppresses parts of your immune system, it can inadvertently allow those specific inflammatory T cells to go rogue.
And that's what triggers the LS for the first time.
Exactly. Or if you already have the condition, this immune shift can drastically change how your disease behaves.
Oh, interesting.
Yeah. Add in the mechanical stretching of the skin as the pregnancy progresses, and you just have a perfect storm.
Okay, so wait, if you already have LS and you get pregnant, what actually happens?
Well, that's the wild card.
Because I would assume, based on that border control analogy, that if the immune system is turning down its defenses, an autoimmune-linked condition might actually calm down.
You would think so, yeah.
But then, like you said, the stretching of the hormones might make it worse. So what does the data actually say?
The data paints an incredibly complex picture. Honestly, when researchers have tracked pregnant patients with LS, the results just highlight how individualized this condition is.
Really? How varied are we talking?
Very. In one notable review of several dozen pregnancies, the outcomes were literally all over the map.
Okay.
About 45% of the women reported mild to moderate symptoms that just sort of, hummed along.
So manageable.
Yeah. And then almost 40% saw absolutely no change from their pre-pregnancy baseline.
Wow. Okay.
But then roughly 18% reported that their symptoms severely exacerbated.
I have to jump in here because I'm looking at another subset of data from a different study that looked at a smaller group of women.
Oh, the study with the 4 patients.
Yes. And all of them experienced complete total remission of their LS during their pregnancy. Like 0 symptoms.
Yeah, it's fascinating.
And then yet another study showed a clean 50-50 split. Half got worse, half improved. How can the data be this chaotic?
It's frustrating, I know.
Is the disease itself just a biological wild card? Or is this a symptom of us just not studying women's health closely enough?
Look, it is undeniably a combination of both. LS is a multifactorial condition, meaning it doesn't have one single predictable biological trigger like, say, a simple virus does.
Right.
But your point about the research gap, that is the quiet part said out loud in all of these studies.
Really? They admit it.
Oh, yeah. The medical literature explicitly notes that data on LS in pregnancy is scarce. We are relying on retrospective reviews and really small case series.
I know big trials.
No, we don't have large-scale, randomized controlled trials tracking thousands of pregnancies with LS, so patients and doctors are just forced to navigate this terrain with fragmented data.
And that lack of clear, uniform data leads us right into the immediate next hurdle for you as a patient.
The treatment dilemma.
Exactly. Because if your symptoms flare wildly, or if they appear for the first time while you're carrying a child, you obviously have to treat the inflammation.
You do. You have to.
But treating any pregnant patient brings up these intense, almost primal anxieties about medication safety.
Of course it does.
I mean, it is drilled into you from the second you see a positive test to avoid all medications if possible.
Wait, aren't steroids usually presented as a massive red flag for pregnant women?
They are. The fear is incredibly common.
Yeah.
And it's rooted in a very protective instinct. But we really have to clearly differentiate between the types of medication we're talking about here.
Okay, so break that down for us.
The anxiety is usually centered around systemic steroids, like a pill you swallow that circulates through your entire bloodstream, crosses the placenta, and can potentially impact fetal growth.
Right, that sounds terrifying.
It is a serious consideration. But for LS, the absolute gold standard of treatment is topical corticosteroids.
Topical meaning just on the skin.
Exactly. You are applying an ointment directly to a very specific, localized patch of skin.
But the clinical guidelines emphasize that you can't just use like a weak, over-the-counter anti-itch cream. They recommend potent and sometimes ultra-potent steroids. They do, yes.
When I hear ultra-potent, my mind immediately thinks, well, that must be more dangerous for the baby.
I get that. But let's go back to your trench war analogy from earlier.
Okay.
Those rogue T cells are entrenched deep down at the dermo-epidermal junction. A weak, over-the-counter hydrocortisone cream is like standing at the surface of the skin and politely asking the T cells to stop.
It's just not going to work.
No, it won't reach them at all. A potent steroid is like a megaphone that delivers a direct, authoritative ceasefire order right to the source of the inflammation.
I love that. A megaphone.
Right. And the major clinical guidelines prefer potent options, but even the ultra-potent options are considered safe to use during pregnancy.
Okay, but how does a topical steroid that strong not make its way into the bloodstream and reach the baby?
It's purely a matter of surface area and absorption mechanics.
Okay.
Because the treated area on the vulva is relatively small, the actual volume of the drug that penetrates the skin, enters the maternal bloodstream, and subsequently crosses the placental barrier is negligible.
So it's just not enough to do damage.
Exactly. The risk of fetal growth retardation, which is the massive flashing red light fear with systemic steroids, it just does not translate to applying a small amount of topical ointment to the vulva.
This brings up a really crucial risk versus benefit analysis that I think often gets skewed.
Oh, completely.
We tend to fixate entirely on the risk of the medication, right?
Right.
But we completely ignore the risk of not treating the disease.
Yes, the risk of doing nothing.
Right. So what is actually happening biologically if a pregnant patient with LS gets too scared to use their steroid cream?
Well, the structural damage can be severe. Without the topical steroid to halt that inflammatory T-cell response, the skin continues to take damage.
It just keeps fighting that trench war.
Exactly. It loses its elasticity, it thins out. You risk developing deep cracks or fissures, which are frankly incredibly painful and vulnerable to secondary infections.
Oh, that's terrible.
And most concerningly, you risk the skin scarring and fusing together, which alters the actual architecture of the vulva. Treating LS during pregnancy isn't just about managing a frustrating itch. It's about actively preventing permanent anatomical changes.
So the topical steroids definitely get the green light.
Yeah.
But our sources are very clear that if you are exploring other treatments, there are some absolute hard no's.
Yes, this is a critical safety parameter. Sometimes patients who don't respond well to steroids are placed on alternative therapies.
Right.
But one class of medications, topical calcineurin inhibitors, they are absolutely not licensed for use in pregnant or breastfeeding women.
Okay, good to know.
But the most vital warning surrounds retinoids.
Retinoids, wait, those are usually associated with severe acne treatments, right?
Yes, both topical and systemic retinoids. They are strictly contraindicated in pregnancy because they are severely teratogenic.
Teratogenic meaning they cause birth defects.
Exactly. They are known to interfere with the fundamental development of the embryo and cause major birth defects.
Oh, wow.
In fact, if you're on certain oral retinoid treatments, the medical protocol actually requires you to avoid pregnancy for at least 2 years after you finish the medication.
2 years. That is intense.
It's incredibly serious.
So the prevailing message is clear. Stick to the topical steroids, use the exact amount prescribed, and do not suffer the inflammation in silence out of fear.
Precisely.
But let's follow the timeline here. Let's say a patient successfully manages their symptoms.
Okay.
They use the ointment, the skin is healthy, the inflammation is at a ceasefire. Fast forward 9 months, you are at the end of the roadmap.
A big day.
The next massive anxiety naturally shifts to the physical act of giving birth.
Yes, the delivery room realities.
I mean, if you have a vulval skin condition that is known to cause skin to lose elasticity, tear, and fuse, well, the idea of pushing a baby out vaginally sounds terrifying.
It does. And it is frequently the #1 concern patients bring to their obstetrics team. There is a very pervasive myth, and it's sometimes even perpetuated by outdated medical advice, that having lichen sclerosus automatically means you are locked into having a cesarean section.
Just automatically.
Yes. The assumption is that the tissue simply cannot handle the mechanical stress of labor, but the clinical data vehemently busts that myth.
The numbers in the literature are actually incredibly reassuring, which, let's be honest, is rare when you're diving into complex medical scenarios.
It really is nice to see positive data.
When researchers reviewed cohorts of pregnant women with LS, the vaginal delivery rates were sitting between 82 and 85%.
Huge numbers.
Yeah. The overwhelming majority are having spontaneous vaginal births.
And the evidence firmly supports that outcome. The major dermatological and obstetrical guidelines explicitly recommend vaginal delivery.
Unless there's another reason, right?
Right, unless there's a completely unrelated standard obstetric reason for a C-section, like the baby being in a breech position.
Makes sense.
What the data shows is that if the LS is well managed, the skin behaves remarkably like normal tissue.
That's so comforting.
Furthermore, if you do experience tearing during delivery, or if the doctor needs to perform an episiotomy, studies indicate that having LS does not impair the perineal wound healing process.
So you heal normally.
Exactly. Your skin will repair itself just as effectively as someone without the condition.
Okay, so if the topical steroids are actually doing their job, calming down those T cells and preserving the skin's architecture, does that mean the physical act of giving birth is completely back to normal?
Mostly, yes.
Or is there still a catch? Like, when is a C-section actually recommended because of the LS?
The exception really lies in cases where the disease has caused severe, unyielding structural damage.
Okay.
A C-section is suggested only in cases of severe, uncontrolled LS where there is significant scarring, adhesion, or literally a narrowing of the vaginal opening.
Which goes back to the untreated cases.
Exactly. This usually occurs in a patient who has not been compliant with their steroid treatment, allowing the inflammation to just run rampant.
So that's purely mechanical issue at that point?
Precisely. If the tissue is severely inflamed, stiff, and inelastic, An obstetrical tear through that specific diseased tissue isn't just a standard labor tear.
It's much worse.
Yes, it will cause prolonged, ongoing morbidity and an incredibly difficult, painful recovery.
Which loops right back to why overcoming the fear of using the topical steroids during the previous 9 months is so critical.
It's all connected.
By using the medication, you are literally preparing the tissue on a cellular level to be supple and elastic for birth.
You are.
And speaking of elasticity, the guidelines mention a proactive physical step that pregnant folks can take, regardless of whether they have LS or not, to prepare the tissue.
Yes, antenatal perineal massage.
What exactly is that?
This is a physical technique where the patient or their partner gently massages and stretches the perineum, which is the skin between the vagina and the anus.
And you do this before birth.
Right, in the final weeks leading up to birth. Mechanically, this increases blood flow to the area and improves the elasticity of the tissue.
Oh, that makes sense.
It's a proven method to reduce the risk of severe tearing during delivery. And for an LS patient whose primary underlying concern is tissue tearing and trauma, adding this to their routine is a highly recommended practice to just build confidence in the tissue's ability to stretch.
I love that. Practical, actionable advice.
Yeah.
Now, here's where it gets really interesting. Let's shift gears, because here's where the story takes a turn I just didn't see coming.
The postpartum period.
Right. The baby has arrived safely. The vaginal delivery was a success. You're holding your newborn. You would naturally think the hard part of managing your LS is over.
That's what everyone assumes.
The immune system is going back to normal. The mechanical stretching is done.
Mm-hmm.
But one particular study tracking postpartum behavior reveals a hidden danger lurking in the weeks after birth.
It's a massive trap.
And it has absolutely nothing to do with biology and everything to do with human psychology.
This is arguably one of the most vital findings for long-term patient care. Researchers didn't just track the physical birth outcomes. They tracked treatment compliance.
Like if they were actually using their creams.
Exactly. They wanted to know how well patients stuck to their prescribed steroid routine before, during, and after the pregnancy.
The numbers before pregnancy showed that about 69% of patients were highly compliant. They were managing their condition well.
Pretty standard.
But once they got pregnant, that compliance rate actually increased to 76%.
From a behavioral standpoint, that makes perfect sense.
Because you're so focused on health.
Right. During pregnancy, a patient has heightened health awareness. You are seeing doctors, nurses, and midwives constantly. Your body is under intense, regular surveillance.
You're super diligent.
Exactly. So you are hyper diligent about following your treatment plan. You are highly motivated to keep everything healthy for the delivery. But then the baby is born. The postpartum period hits.
And the compliance rate absolutely plummets. It drops down to 60%.
And the clinical consequence of that sudden drop is stark.
What happens?
The research noted that severe relapses of lichen sclerosus developed almost entirely in the postpartum period, specifically among the patients who abruptly neglected their topical steroid treatment after the baby arrived.
I mean, I think anyone listening who has ever brought a newborn home recognizes this phenomenon instantly.
Oh, for sure.
I call it newborn tunnel vision. You are so profoundly physically and emotionally consumed by keeping this fragile, tiny human alive that your own basic needs completely vanish from your radar.
They just disappear.
You aren't sleeping. You're barely remembering to drink water or shower. You certainly aren't remembering to apply a highly specific dermatological ointment twice a week.
No, of course not.
The baby becomes the sun, and the mother's health just falls completely into the shadow.
It is an incredibly powerful behavioral trap. The physical exhaustion is compounding the emotional distraction. But, it's not just the mother's tunnel vision. It's a systemic failure of the medical timeline.
That's it.
After birth, the medical system shifts almost its entire focus to the pediatrician and the infant's weight gain.
That's true. The baby has a million appointments.
Exactly. The mother is largely discharged and left to her own devices until a standard 6-week checkup. That is 6 weeks where a chronic inflammatory condition can quietly rage back to life unchecked.
Wow. 6 weeks is a long time for those T cells to do damage.
It is. This gap in care is so well documented that clinical guidelines explicitly codified a recommendation for it. They state that careful surveillance in the postpartum period for LS patients is mandatory to ensure that treatment is continued.
But, writing careful surveillance in a medical guideline doesn't actually solve the problem of a mother who's too exhausted to function.
No, it doesn't.
How do we practically fix that? How can medical systems better support the mother's ongoing care when all eyes are structurally designed to be on the newborn?
Well, it requires proactive changes before the baby is even born. Obstetricians and dermatologists need to actually communicate and create an integrated postpartum care plan.
Like they need to talk to each other.
Yes. The discharge paperwork shouldn't just be about newborn feeding schedules. It needs to include explicit, scheduled check-ins on the mother's chronic condition management.
I love that.
And beyond the medical system, it requires mobilizing the patient's support network. Partners, family members, or friends need to be educated about the LS treatment.
So they can help.
Right. They need to be the ones to remind the mother and physically take the baby from her arms to allow her the 5 minutes she needs to manage her own health.
That is such a vital point. So what does this all mean for you listening right now? Let's recap the journey we just took through this diagnostic wilderness.
Let's do it.
First, yes, lichen sclerosus can absolutely develop or flare during pregnancy. Your immune system is lowering its borders to protect the baby, which can give those inflammatory T cells the opportunity to cause chaos in your skin. Second, if you have it, you must treat it. Potent topical steroids are the gold standard. They are safe for the baby because they stay localized, and they're crucial for protecting your skin's architecture from permanent damage and fusion.
Absolutely crucial.
Third, you absolutely can have a successful vaginal birth. The data is overwhelmingly on your side, proving that well-managed LS tissue can handle labor and heal beautifully.
It really is reassuring.
And finally, the postpartum period is the secret boss fight of this whole experience.
The secret boss fight, I like that.
It is. The biological shifts might be stabilizing, but the psychological and systemic hurdles are at their peak. You have to fight through the newborn tunnel vision, lean on your support system, and remember to care for yourself so you don't suffer a severe relapse when you are at your most vulnerable.
That is the most important takeaway, I think.
Whether you are dealing with LS yourself, whether you know someone who is, or whether you simply care about understanding the massive, often silent complexities of women's health. Arming yourself with this knowledge is your best defense against fear.
You know, before we wrap up, there is a lingering thought hidden in this data that I find incredibly compelling. And I think it points to the future of how we view this condition.
Oh, what's that?
Remember the subset of women we talked about earlier? The ones who experienced complete total remission of their chronic, supposedly incurable LS during their pregnancies.
Right, the ones whose immune systems suppress themselves so perfectly that the disease essentially just turned off for 9 months.
Exactly. If the unique temporary immune suppression created by the biology of pregnancy can force a chronic autoimmune-linked condition like lichen sclerosus into complete remission, well, it raises a massive question.
I think I see where you're going with this.
Could studying the precise biological mechanics of pregnant women hold the key to finally finding a permanent cure?
Oh, wow.
If researchers can figure out exactly what the pregnant body is doing to quiet those specific inflammatory T cells to protect a fetus, we might just discover the biological switch to turn off the disease forever, for everyone.
Now that is a roadmap worth exploring.